Noobs. So we have started a new podcast for auditory listeners and it will be available on every major platforms. Please kindly hit the follow button and subscribe our YouTube channel for the daily updates. Genital tuberculosis. Incidence. The incidence of genital tuberculosis varies widely with the social status of the patient and her environment. The incidence is about 1% amongst the gynecological patients attending outpatient department in the developing countries. Incidence is high, that is 5 to 10% amongst the patient with infertility. With the prevalence of HIV infection, incidence of genital tuberculosis is rising. About 10% of women with pelvic tuberculosis have urinary tract tuberculosis. Genital tuberculosis affects the genital organs like fallopian tube, endometrium, cervix, ovaries, pelvic peritoneum, vulva, vagina, etc. The mode of spread. First one is hematogenous. From any of the primary sites, the pelvic organs are involved by hematogenous spread in about 90% cases. If the post-primary hematogenous spread coincides with the growth spurt of the pelvic vessels, the genital organs, the tubes in particular, are likely to be affected. Thus, the pelvic organ are infected during puberty. If the spread precedes the growth phase, the genital organs are spared. The infection remains dormant for a variable period of time, that is 4 to 6 years, until clinical manifestations appear. The next one is lymphatic or direct. The pelvic organs are involved directly or by lymphatics from the infected organs such as peritoneum, bowel or mesenteric nodes. Ascending. Although difficult to prove, but sexual transmission from a male with urogenital tuberculosis is possible in vulvar, vaginal or cervical lesion. Clinical features. The general signs include weakness, low-grade fever, anorexia, anemia, night sweats. Per abdomen, irregular tender mass in lower abdomen arising out of pelvis. May feel duffy due to matted intestines. Per vaginum, vulvar or vaginal ulcer, thickening of the tubes, bilateral pelvic mass. The symptoms include infertility, menorrhagia, amenorrhea, oligomenorrhea, chronic pelvic pain, vaginal discharge. Investigations: blood, Mantoux test, chest X-ray, nucleic acid amplification with PCR, lymph node biopsy, hysterosalpingiography, imaging test, laparoscopy. The differential diagnosis include pyogenic tubo-ovarian mass, pelvic endometriosis, adherent ovarian cyst and chronic ectopic pregnancy. Treatment options: pharmacological therapy include isoniazid, rifampicin, pyrazinamide, ethambutol. Chemotherapy, anti-tubercular chemotherapy is the treatment of first choice. Initial phase. 4 drugs are used for 2 months to reduce the bacterial population and to prevent emergence of drug resistance. The drugs used are isoniazid, rifampicin, pyrazinamide and ethambutol. Ethambutol is essential to those who have been treated previously or are immunocompromised. In case of HIV positive individual. Continuation phase. Treatment is continued for a period of further 4 months with isoniazid and rifampicin. This standard regimen may be used during pregnancy and lactation. Stopping of therapy. After about a year of treatment, diagnostic endometrial curettage is to be done. If the histological and or bacteriological examinations becomes positive, the treatment must be continued further. If these are negative, the endometrium is examined at an interval of 6 months. A patient may be considered cured. At least 2 reports including histological and bacteriological examination become negative. Majority of the patients, that is 90 to 95%, respond well to chemotherapy. Multi-drug resistant tuberculosis is defined as infection with Mycobacterium tuberculosis that is resistant to 2 or more agents including isoniazid. HIV negative patients who are MDR have high mortality rate, that is 80%. Such patients are treated with 5-drug regimen center for drug control. Surgery: salpingo-oophorectomy, isolation excision of tubo-ovarian mass, drainage of pyometra, and repair of fistula. Thank you all. Have a nice day.